So let's move on to part 3 of lesson 3, primary care. So let's talk about some concepts that are important in terms of primary discussion about primary care. One of them is community-oriented primary care. And what is community-oriented primary care? How can you call a primary care practice as community-oriented? Well, first of all, it needs to incorporate elements of effective primary care delivery, as we have discussed previously, but then add a population-based approach to identify and address the community health problems. This entails for a provider to be socially conscious and be aware of the health issues facing the community that he or she serves. Providers are well-respected members of society, and therefore they can influence health policy that best serve their patient population. This also means that a provider should think beyond just taking care of an individual patient, but also the needs of the community where the patient lives as well, because it influences the patient's health outcomes. So for example, a pediatrician can advocate for green spaces or safe playgrounds to promote physical activity among his or her patients. Considering both the health needs of the individual patient and the larger community has its own challenges. It is not hard to identify what these needs are, but it is the means and how to meet these needs that can be very challenging. For example, the pediatrician cannot just magically raise the money to have a safe space for children and community to be physically active. This requires a concerted effort among other stakeholders in the community. It is also not easy to address not just the clinical needs of patients and include their psychosocial needs for various reasons. It's not easy because of these two main reasons. First is workforce shortages. So having to go beyond the scope of clinical practice may be hard for a physician if there are not enough providers to cover, the extent of the practice. This could mean that your visit period gets cut short. Also, the lack of financial incentives to provide care beyond individual health needs may be prohibitive for providers for them to go beyond the scope of their clinical practice. There are worldwide challenges that have provided the incentive for team-based primary care. So examples of these challenges are the shrinking medical workforce. There are just less and less people that work in the medical field. The healthcare demands are increasing, but we seem not to have enough supply of primary care providers to provide healthcare. And how to increase the diversity in the healthcare team to include a wider range of health professionals, including those from allied health practices like therapists. That's one of those challenges as well. And to meet these challenges, several approaches or models to implementing primary care are being used around the world. So first is to redefine or extend the roles of primary healthcare professionals. For example, HIV patients are now routinely seen by primary care physicians who have additional training. No longer just confined to infectious disease subspecialties. So this makes it easier for patients to actually have a more coordinated, continuous care because they're basically seeing their own primary care provider to manage this infectious disease that is now also considered a chronic disease. Second is to refocus and harness the roles of non-physician practitioners. We're talking about nurse practitioners, physician assistants, to provide quality primary care. And it seems like in New York, we're actually good at this. There's also a need to utilize other healthcare professionals not traditionally utilized, such as dental health aides, therapists, technicians, in rural areas where there is lack of oral healthcare professionals. So, we need to promote a biopsychosocial approach in primary care by including social workers, pharmacists, community health workers, which then expands the range of expertise. So in Canada, since 2004, the federal government has encouraged the formation of interprofessional healthcare teams and has placed greater emphasis on health promotion. Interprofessional care networks care for patients with chronic health conditions. And the government has also developed new approaches to primary health care, such as the family health team. Now, in the United States, we call this as the patient-centered medical home, and it's firmly supported by NCQA, the National Council for Quality Assurance. On the other hand, in Australia, primary care practices have traditionally been operated as a private business, so they shifted away from this. And a shift away from medically qualified general practitioners working as solo practitioners, providing episodic opportunistic care. And what happened was general practitioners now include 2 to 5 primary care physicians. It's like doing the group practice. And they provide a greater focus on prevention, early intervention, and structured chronic disease management using multidisciplinary care team approaches. Let's talk about how effective primary care is. Preventive care is a vital part of primary care practice. So for preventive care to be most effective, we need a patient to receive continuous care with one provider because of the familiarity with the patient's history. Also, research have shown that a good pediatrician, for instance, encourages patients or guardians to bring their children for regular health visits and follow through with recommended well child care visits. So then again, that's the relationship you have with your child's pediatric primary care provider. And with preventive care comes early detection of many chronic diseases such as heart disease, hypertension, diabetes, and most cancers. In terms of hospitalizations and use of emergency care, evidence shows that there are lower rates for hospitalizations of health conditions that can otherwise be controlled or maintained in primary care. So for example, children with controlled asthma, and the control of asthma is done in the primary care setting, they tend to have less emergency department visits. They are also less likely to be hospitalized for asthma exacerbations simply because their asthma is well controlled. In terms of cost of care, areas with high primary care physician to population ratios experience lower total health care costs. So while high rates of specialist physicians have been shown to be associated with higher and perhaps unnecessary utilization, having sufficient availability of primary care physicians has been proven to be essential for preventive and primary care, and when needed, referrals to appropriate specialty care. Morbidity, by the way, refers to sickness or injury in any given population. Entry-level access through primary care is associated with better health outcomes, and therefore lower morbidity in a given population. Patients with better experience of primary care reported better health, such as lower occurrence of low birth weight infants. We're talking about prenatal care patients here. Lower occurrence of infant mortality, which is death of a child before turning a year old. And primary care, having enough primary care or adequate primary care in a given population has also shown lower morbidity in hypertension, meaning there's better controlled hypertension. So mortality, on the other hand, is defined as deaths in any given population. And increases in supply of primary care physicians results in lower death rates, from preventable diseases. So it just makes sense. There are lower deaths that occur in a given population where there is enough primary care because of preventive care. And having adequate supply of primary care physicians in reference to the size of the population served directly influences higher life expectancy. People tend to live longer. Death rates from stroke is low, meaning there's a high survival rate for people that experience stroke. Maternal and infant deaths after giving birth or being born also tend to be lower. and overall, just lower mortality in a given population. So let's talk a little bit about the medical home strategy. So in 2006, the American College of Physicians, they're also referred to as ACP, recommended the medical home care model for the provision and financing of primary care because, according to them, it incorporates principles of the chronic care model, which emphasizes that chronic conditions are best managed by a multidisciplinary practice-based teams while using evidence-based guidelines, appropriate health information technology, and accountability for the quality and value of care. It also improves patient health outcomes and satisfaction, reduces medical errors, and saves costs without compromising health outcomes. It is proven to be effective in providing comprehensive, accessible, and continuous primary care, which is part of domains of primary care to start with. And a growing body of literature now demonstrates that medical homes may improve health outcomes, reduce disparities in access and quality of care, and ultimately lower costs over time. I mentioned this earlier, but the National Committee for Quality Assurance, or NCQA, has this recognition program called Patient-Centered Medical Home, and it's the most widely adopted patient-centered medical home evaluation program in the United States. So you could actually apply for this if you're a primary care practice and get accreditation. And once you get this, there are 3 levels, level 1, 2, and 3 being the highest. It results in higher revenues, particularly for Medicaid patients. So it helps community health centers a lot. In 2009, the Federal Health Information Technology for Economics and Clinical Health Act, that was a law that was passed, provided incentives for the meaningful use of electronic health records, or we also refer to them as EHR, to improve healthcare processes and outcomes by tracking and reporting on quality measures. And then also it encouraged electronic prescribing. This means no more handwritten prescriptions. So prescriptions are written using the patient's electronic chart and then securely sent, again, electronically to the patient's pharmacy. And this has helped to curb controlled substance abuse, or, those handwritten scripts that are circulating out in the street and being sold unscrupulously. So in addition, in 2010, the Affordable Care Act proposed the use of health information technology to improve patient safety by reducing medical errors and also to ensure patient-centered care. Now, since primary care is now also a setting where chronic conditions like diabetes is cared for, information technology helps with clinical decision support. So this helps physicians to make immediate and correct clinical decisions in treating patients because it is easy to access patient information and history. Now, health information exchange allows providers to access other systems so that they can better take care of their patients. And this ability for primary care providers to access notes on a patient's emergency room visits, for instance, is really, really helpful. Usually, after going to the emergency room, the primary care provider has to see the patients. Especially if it's within the same integrated delivery service, then you just share one electronic health record. Disease registries, which is simply a list of patients, allows physicians to create a list of their patients that require attention. For example, they can create a list of their diabetic patients. So they would say, how do I better take care of my diabetics? Well, first of all, I need to know who they are. So he can then create, through the electronic health record system, a registry or a list of his diabetic patients, monitor them individually, look at their labs and things like that. But just like any relatively young technology, there are challenges in the use of information technology in healthcare. Electronic health records, or EHRs, in primary care is relatively new. I would say it's at least been around for the most part, maybe at least in the last 10 years. Is now required by the government, and the users of health information technology may not have mastered the more advanced functions. Each time you upgrade or change the software, of course, you need new training. And you need this for quality improvement. EHRs also require significant investments, so it could be expensive. You invest in the software itself and capital, maybe newer computer systems, operating systems, and then you have to train your clinicians and your staff. And of course, there's a steep learning curve and all those things. So there is a video after this lecture video. It's about Emory's patient-centered primary care model, and I would want you to watch that as well. So this concludes this lecture series for Chapter 7, Outpatient Services in Primary Care. After watching this video on the patient-centered primary care model at Emory University Hospital in Atlanta, please make sure to participate in the discussion board, because that is your assessment, and that concludes the whole session itself, Chapter 7. All right, so good luck with everything, and I am looking forward to grading your posts, your threads, as well as your responses to your classmates in the discussion board.